Here we are back with our fourth module of ECG series. In this video, we'll discuss about the chamber hypertrophy and their ECG changes. Atrial hypertrophy. Atrial hypertrophy can be diagnosed by studying P waves which are best seen in lead 2. P wave represent depolarization of both right and left atria. SA node initiates depolarization in right atrium. So initial part of P wave is contributed by right atrium and later part of P wave is contributed by left atrium. In left atrial hypertrophy, second component of P wave is delayed and prominent. So we get wider bifid and notched P wave, that is wider than 2.5 small squares. As it is common in mitral valve diseases, it is also called P mitrally, which is better seen in lead 2, also in lead 1 and lead AVL. P in lead V1 is biphasic with prominent deep negative deflection more than 1 mm depth and small initial positive deflection. This ECG shows wide and notched P wave, which is 3 small squares wide, and P in lead V1 is biphasic with prominent deep negative deflection. This is due to left atrial hypertrophy. In right atrial hypertrophy, initial component of P wave is prominent. So P wave is tall and peaked, which is taller than 2.5 small squares. As it is common in pulmonary hypertension, it is also termed as P pulmonally, which is best seen in lead 2, also in lead 3 and AVF, and also sometimes in lead V1. P wave in lead V1 is biphasic with tall initial positive deflection more than 1.5 mm with a small negative deflection. Only positive deflection is also diagnostic. This ECG shows very tall P pulmonally, which is 4 small squares tall, and P in lead V1 is biphasic with tall initial positive deflection. This suggests right atrial hypertrophy. In biatrial hypertrophy, P wave in lead 2 is taller than 2.5 small squares and wider than 2.5 small squares. Ventricular hypertrophy. Ventricular hypertrophy is diagnosed by pattern and amplitude of QRS complexes in chest leads, that is from V1 to V6. We already know normal pattern of QRS complexes from our first module. Let us revise it again. In lead V1, we get small R wave and deep S wave. Proceeding to lead V6, height of R wave progressively increases and depth of S wave progressively decreases. Somewhere in lead V3 and V4, height of R wave and depth of S wave are equal. In lead V6, we get tall R wave and very small or absent S wave. In left ventricular hypertrophy, pattern remains the same, but amplitude of waves increases. That is, normal progression from negative deflection in lead V1 to positive deflection in lead V6, but the amplitude of waves increases. So measure amplitudes of S waves in lead V1 or V2, whichever is larger, and amplitudes of R waves in lead V5 or V6, whichever is larger, to diagnose left ventricular hypertrophy. The criteria of diagnosis are if any of these, that is S in lead V1 or R in lead V6 is more than 25 mm, or the addition, that is SV1 plus RV6 is more than 35 mm, then diagnosis of left ventricular hypertrophy is made. It is usually associated with left axis deviation, and P mitrally of left atrial hypertrophy may be seen in lead 2. Side note, in young and thin person, this voltage criteria is not diagnostic. In young person, S in V1 and R in V5 or V6 should be greater than 40 mm. This ECG shows normal progression from negative deflection in lead V1 to positive deflection in lead V6, but the amplitudes of waves have increased. Now let's measure the amplitude of S wave in lead V1, which is 16 mm, and amplitude of R wave in lead V6, which is 22 mm. So SV1 plus RV6 equals to 38 mm, which is greater than 35 mm. So this is left ventricular hypertrophy. Right ventricular hypertrophy. In right ventricular hypertrophy, pattern of QRS complexes in chest leads will be changed. That is, in lead V1 we get prominent R wave, in lead V2 also prominent R wave, in lead V3 and V4 equal R and S waves, in lead V5 prominent deep S wave, and in lead V6 also prominent deep S wave. So when there is prominent R wave in lead V1 and deep S wave in lead V6, right ventricular hypertrophy is suspected. The criteria of diagnosis are: R in lead V1 is greater than 7 mm, S in lead V5 or V6 is greater than 7 mm, or addition of both, that is RV1 plus SV6 greater than 10 mm. This ECG shows change pattern of QRS complexes from lead V1 to V6. Now let's measure the amplitude of waves. RV1 is equal to 16 mm, which is greater than 7 mm, and S in V6 is 10 mm, which is greater than 7 mm, and their addition is also greater than 10 mm, which is 26 mm. So this is due to right ventricular hypertrophy. Right ventricular hypertrophy may or may not be associated with right axis deviation, and often there will be P pulmonally of right atrial hypertrophy. Strain pattern in ventricular hypertrophy. When left ventricle has to work against resistance, as in hypertension or aortic stenosis, there will be hypertrophy of its muscle, which is seen in lead V5 and V6 as strain pattern. That is, ST segment is slightly depressed and T wave is inverted in addition to tall R waves. In this ECG, we see, along with tall R waves representing left ventricular hypertrophy, we see slightly depressed ST segment and inverted T waves, which is due to left ventricular hypertrophy with strain. Right ventricular hypertrophy with strain, which usually occurs due to pulmonary stenosis, will show depression of ST segment and inverted T waves in lead V1 and V2. Note prominent R wave of right ventricular hypertrophy and strain pattern, that is ST segment depression and T wave inversion in lead V1 and V2 in this ECG. This is due to right ventricular hypertrophy with strain. Biventricular hypertrophy. Biventricular hypertrophy is diagnosed when there is tall R wave in lead V1 representing right ventricular hypertrophy and deep S wave in lead V1 and V2, and tall R wave in lead V5 and V6 representing left ventricular hypertrophy. Note tall R wave representing right ventricular hypertrophy in this ECG. Along with this, there is deep S wave in lead V1 and V2 and tall R wave in lead V5 and V6 representing left ventricular hypertrophy. So this ECG is due to biventricular hypertrophy. So this is all for today. Don't forget to mention how our videos have helped you to read ECG in your clinical practice in our comment section below. Thank you and keep watching.